Thank you for joining us today for a program on Parkinson's disease. Today I'll be informing you about understanding early onset idiopathic Parkinson's disease, which we refer to as IPD, and its diagnosis. We're going to talk about the overview of treatment, the pathophysiology, and pathophysiology means the pathology that's in the brain and the physiology that's involved. We're going to talk about etiology, which means how does this disease come about? What makes this disease happen? Then we're going to talk about diagnosis, and then I'm going to go over the signs and symptoms of Parkinson's disease. And there are really two major areas, non-motor symptoms and motor symptoms. We're going to talk a little bit about biomarkers. Let's first talk about an algorithm for the treatment of early Parkinson's disease, how we treat it medically, because it'll give us an idea how to understand other parts of this discussion. We make the diagnosis as best we can, and that diagnosis is done on a clinical basis. There is really no marker at the present time. Once we have the diagnosis, we decide whether we're going to treat the patient or whether we're not going to treat the patient. In some patients that are very early and have no impairment or any reduction in activities of daily living, we decide just to watch and see the patient back at a later date. However, most patients today I treat very early. When we decide to treat the patient, we evaluate the various characteristics that the patient has with their Parkinson's disease. And we divide this into three categories. And this is an algorithm that Shapira and others started. But in 1994, Dr. Kohler, Silver, and Lieberman did the very first algorithm, and I revised it in 1998. First, on the right, is the mild motor disability without cognitive dysfunction. In the middle is mild to moderate disability without cognitive impairment. And to the left is the moderate to severe disabled patient who is usually older and has some cognitive impairment plus comorbidity. The reason we decide to develop these various groups is because which group the patient is indicates how aggressively we may treat the patient and also the side effects that they may get. So in mild to moderate disabled patients, we think about beginning usually with an MAO type B inhibitor, which is a drug like rasagiline or selegiline. We start the patient on that. They do get better. The studies show that they do have an opportunity to improve activities of daily living and probably motor function. But all patients progress. So as the patient progresses, or if the patient has mild to moderate disability when we first see the patient, we usually start with a dopamine agonist. The reason we start with a dopamine agonist is to delay the need for L-DOPA, which has some significant or moderate side effects. In the mild to moderate disabled patient, we can use a dopamine agonist such as pramipexole, ropinirole, or rotigotine patch. We start the patient on that, see how they do. We go low and we go slow. And oftentimes we add in other drugs like an MAO type B inhibitor and sometimes anticholinergics or a drug like amantadine hydrochloride. But in the group of patients that have moderate to severe disability or are older, usually over the age of 70, and have other cognitive impairment or have comorbidity, we think about using initially L-DOPA. And as our patients who are diagnosed earlier develop into this stage, L-DOPA is the most robust therapeutic drug we have. They get a good response. If they don't get a good response, by and large, they don't have Parkinson's disease. We follow these patients and we watch for side effects that can occur. Patients who have comorbidity of cognitive impairment have a greater incidence of side effects, especially with dopamine agonists. Now this next slide talks about the pathophysiology and shows you where the initial dopaminergic neuronal loss occurs and the tracts of the nerve that go to other parts of the brain. So in the bottom of this slide, we have the midbrain. And this is where the substantia nigra is. This is where the pars compacta has dopaminergic neurons. And in Parkinson patients, before they're diagnosed, they have usually a 50 to 60% neuronal loss in the substantia nigra. Now, the cells that are present and are healthy, they have their cell body in the substantia nigra, but their axon goes all the way up into the caudate and into the putamen. And this is the area where the presynaptic terminal is. And it's also the area where the dopamine is released. And it's an important area because it's also the area where we use the DAT scanner information, which I'll talk to you about later. This slide shows us a number of important aspects of Parkinson's disease. First of all, on the left, we have the presynaptic neuron. That's the neuron that comes from the substantia nigra up to the caudate and the putamen. That neuron, if it's normally functioning, has L-DOPA converted to dopamine, and then that dopamine is released. And dopamine is a neurotransmitter. On the right-hand side is the postsynaptic neuron, which has the receptors where the dopamine attaches to, and that sends the message. It's the neurotransmission. It's a message that is sent from presynaptic neuron to postsynaptic neuron. And when you have dysfunction of this neurotransmitter, you have symptoms that can result in significant impairment of the Parkinson patient. Can have rigidity, slowness, and tremor. This messaging system actually controls this. If it's working normally, then the symptoms aren't present. But when there's a loss of cells in the substantia nigra and you have reduction in the neurotransmission of dopamine, you have symptomatology that affects activities of daily living. What we want to do is try to improve in Parkinson patients this messaging system. And we do that by increasing the amount of dopamine. Now, this shows us the sites of action of Parkinson's disease drugs. So we take L-DOPA by mouth. It's absorbed in the small intestine. And as it's absorbed in the small intestine, it gets into the blood. In the blood, L-DOPA, which is Sinemet, and Sinemet is carbidopa, levodopa, it can be broken down into several other byproducts. But we like to block those pathways to get more available L-DOPA into the brain. So we use carbidopa to block the pathway to dopamine, and we use the COMT inhibitors, which is entacapone and tocapone, to block another pathway from getting it to 3-O-methyl-DOPA. So the L-DOPA gets inside the brain through the blood-brain barrier. And now we have L-DOPA that's taken up by this presynaptic neuron on the left. But these are dopaminergic neurons. When the diagnosis is made, there's 50-60% of these are already dysfunctional or are not functioning. So what happens to the L-DOPA? It's converted into dopamine, and the dopamine is contained in vesicles, the little red dots you can see, and those vesicles attach to the membrane, and then they are released into the synaptic cleft. The synaptic cleft is the area where the dopamine or the neurotransmitter is present, and then it attaches to the dopamine receptor on the postsynaptic receptor site. Now, rasagiline and selegiline are MAO type B inhibitors, and those drugs are very important because dopamine that's floating around is broken down by an MAO type B enzyme. To get more available dopamine, we use MAO type B inhibitors such as selegiline and rasagiline. So it allows more dopamine available to attach to the postsynaptic receptor site. And then we have dopamine agonists. And dopamine agonists are pramipexole, ropinirole, and rotigotine patch. And they bypass the presynaptic area. So we have dysfunction or loss of cells. These dopamine agonists attach right to the postsynaptic dopamine receptor, and they help make the neurotransmission. So, in summary, we've had a message system, which is dopamine, travels to the postsynaptic receptor site, sends a message, and we want to have more normal activity. Now the pathology. The pathology is what you see in the brain at autopsy or in microsections of the brain. And the hallmark of the pathology for Parkinson's disease is the Lewy body. And it contains alpha-synuclein. It is the protein that is deposited in cells in Parkinson's disease. And you can see it here. It is the eosinophilic or red pink-like color, and it has a halo around it, and it's a cytoplasmic deposition. And we think this is the hallmark of Parkinson's disease. It's also the hallmark of dementia with Lewy bodies, and it occurs first in the lower parts of the brain. Now, Dr. Brock did a study of brains and described the evolution of Lewy body pathology as to time as a development and the journey in Parkinson's disease. The first areas of involvement with Lewy bodies are in the olfactory nerve and in the medulla or the brainstem in the vagus nuclei. It increases and moves forward from the medulla into the brainstem, and then stage 3 and 4, it goes up into the midbrain, other areas, and in the last stages, it goes into the temporal lobe and throughout the cortex. It's the latter part that gives any of the non-motor symptoms. Now, the proposed etiology of Parkinson's. Etiology means what is the cause of this disease? Most people think it's what we call a double hit phenomenon. It's genes along with environment. And in Parkinson's disease, some of the genes that we have are alpha-synuclein, Parkin, and LRRK2. We now have 16 genes, and more are really being discovered all the time. They combine with an environmental insult of some type, or with styles of living, or with our aging. And the environment in Parkinson's is thought to be as an insult process of pesticides and fungicides. They combine together with a pathological mechanism, and that mechanism is protein aggregation. There is a deposit of alpha-synuclein in the neurons, and we think that is probably why these cells die. But there may be other reasons, or maybe a combination of reasons. Mitochondrial dysfunction, oxidative stress, some type of inflammation, or some kind of local excitotoxicity. But with this combination of genes, environment, the pathological mechanism, we have the cell death, or what we call apoptosis. Epidemiology is who gets this disease and why. Does this occur in certain groups and in certain areas? Well, the annual incidence of Parkinson's in the United States is about 20 per 100,000. But age is the greatest risk factor. So there are about 1 million people in the United States that have Parkinson's, and they have the average age of onset somewhere between 60 and 61. But as the population gets older, you can see that you have a greater incidence. And in the older age group, it can be as common as 1 in 100. The graph shows you the incidence. The vertical is the number of patients and how many per 100,000. The top is 100, and the horizontal bar is the age. And you can see it starts getting more common at 60 to 69 and 70 to 79, and it tapers off a little in the 80s. But in that later age group, it's 1 in 100. So the epidemiology, genetics and environment. Early and late lifestyle and habits play a significant role. Age is the greatest risk factor. The aging process, everybody ages a little different, but the aging process and how we accumulate comorbidity makes a difference. And maybe some of these diseases and cases occur by chance. We don't know the actual cause of many of them, so we have to say there is some reason they have, and it could be by pure chance. However, the accumulation of medical deficits, mental or physical, play a big role in our journey of our disease and how we deal with the disease. And so it's very important that today, early as possible, you improve and maintain your physical and your mental health. Healthcare status plays a significant role in your journey with Parkinson's disease. We want to avoid accumulated risks. For example, obesity. It is a significant risk factor. It increases your comorbidity with Parkinson's disease. You want to lose weight and reduce your overweight state. Alcoholism is a major role in some patients with their comorbidity in Parkinson's disease. Smoking, even though it's been shown that it has some protective basis in Parkinson's disease, it is a significant risk factor for comorbidity, such as hypertension, stroke, and heart disease. If you have diabetes, you want to control it or avoid it by losing weight and exercise. There's recent studies now in Parkinson's disease and some other neurodegenerative diseases that exercise is of benefit. So if a person exercises 5 days a week and gets his heart rate up to 60 to 80% maximum heart rate, he has a significant chance of reducing the progression of the disease. Importantly here, individual responsibility is the key for all of these above mentioned items. Etiology of Parkinson's disease. What is the etiology? We talked about it. We don't have a specific cause for many of the patients, but genetic and environment play a role. Rare families with inheritance of abnormal genes certainly play a role, but they're usually the younger patient. And environmental insults play a larger role in patients who have their onset in later years, especially over 50. Now today, we can get some genetic testing for Parkinson patients through a program called 23andMe. You can Google that 23andMe and find out how to do it. You give a saliva sample in a tube and you send it off. The company Google has done significant benefit here of helping pay for this program. Another interesting gene is LRRK2. We know more about that. It's considered to be about 1 to 5% of the sporadic cases of Parkinson's and 5 to 13% of the early onset familial cases. We now have 16 genes to help us in understanding Parkinson's disease. But there's more data that's going to be obtained as we've been able to map the genome, and the cost of doing that is much less. The problem so far is the knowledge from the genetic abnormalities isn't really helping us so far with therapeutic benefit, but it looks like that may be on the horizon. Now, we talked about the fact that there is dopaminergic terminal loss because the substantia nigra has cells that are dysfunctional or die, and they have their axons up into the area of the putamen. This graph shows, with the vertical showing change from baseline, the high part is where the cells are normal, and with time, 1 year, we have with the red line, this is what happens to normal people. In 1 year, they only lose about 0.8% of their presynaptic dopamine nerves, and their cell loss is very little. But the patient with Parkinson's disease, they have a significant reduction, and they lose about 11% of their dopamine cells in 1 year. So there's a major difference, and this occurs mainly in the substantia nigra. Let's talk about ways of thinking of the phases of Parkinson's disease. Now this slide talks about 2 phases, premotor phase and motor phase, which are on the horizontal line, and it talks here about the percentage of the neurons that are remaining on the vertical. So the top is they have normal number of dopamine neurons. Recently, they've been talking about using 3 phases, but I'm going to concentrate on the 2 phases, and they're premotor on the left and a motor phase on the right. And you can see there are 3 different lines. The red line shows as the Parkinson patients increase their journey into the disease process, we have a reduction in the number of dopamine neurons. And about halfway through the premotor phase, we have the onset of non-motor symptoms, which I'll describe to you later. Those non-motor symptoms occur more, and we accumulate more of them, but at the time of diagnosis, we base our diagnosis on the aspects of the motor symptoms. And then after that, the dopamine neurons continue to decline, and the number of motor symptoms increase, as do the number of non-motor symptoms. Today, it's being proposed a three-phase analysis of the Parkinson journey, and to the left is the preclinical phase, a phase that is orientated toward genetic aspects and other aspects we may be able to test by biomarkers. So there are potential markers in the patient with Parkinson's, especially premotor, and this slide shows some of them. The radiotracer imaging of the DAT scanner, that is a picture of an isotope that is taken up in the putamen. And the more isotope that is taken up, there is more function that appears to be normal. We also have tests that are olfactory testing, and it's known that in Parkinson patients that you have about 80 to 90% of the patients have lost their olfactory sensation. We also have ways of looking at the stool frequency. If you have one stool every 3 days or less, especially in an Asian population, you may have a propensity to develop Parkinson's disease. We talked about the genetic testing. There is some transcranial ultrasound tests that can be done. That's not as commonly used. And there are some testings that are used for cardiac imaging that test the phenomenon where there is dopamine loss in the sympathetic fibers that occur in the heart. We have the opportunity with the DAT scanner to image the dopamine in the caudate and the putamen as it's taken up in a transporter that transports dopamine back in to the presynaptic neuron. This gives us an idea of how the neuron that comes from the substantia nigra to the putamen is functioning. So if there's a reduction in this picture or in this uptake, it means that these cells are not functioning as normally or they are dead. You can see on the left here, this is a healthy subject, and that shows significant normal uptake. On the right, though, you can see that this is an early Parkinson patient, and there is reduction in this uptake on the DAT scanner. And that means that there is dopaminergic neuronal loss, and it is either a loss of the cell or it is some type of dysfunction. And this helps us with the diagnosis. This scan is positive in Parkinson patients. It can also be positive in some atypical Parkinson's, but usually in patients like essential tremor and people with vascular disease or maybe drug-induced disease, it is usually normal. Now, what's the burden of disease with Parkinson's? Well, there's reduced quality of life, there's reduced activities of daily living, patients can become depressed, they can have cognitive loss, but oftentimes with depression and cognitive loss, they have associated apathy, anxiety, and later on they can have hallucinations. Parkinson's can have frequent falls and fractures, and that dramatically reduces their quality of life. Parkinson's disease, as the journey goes on, increases office visits, hospitalizations, there's a greater chance of nursing home placement, and obviously there's a greater cost to the patient and to society. Now, how do we make the diagnosis of idiopathic Parkinson's disease? I like to use the term trio or 3+1. We have resting tremor, which is a 4 to 6 cycle per second tremor. We have bradykinesia or akinesia, which is slowness. And we have rigidity, which is stiffness. And these three key motor features have asymmetry, more on one side and the other. And with these 4 points, we oftentimes can make the diagnosis of Parkinson's disease, and clinically and early, we are usually right 75% of the time. As the disease progresses, and if they're responsive to L-DOPA, they remain asymmetrical, and they continue to have a good response to L-DOPA and may have dyskinesias and wearing off, we have a greater certainty that we are right about the diagnosis. But postural instability occurs later. And if you see someone with postural instability very early, it's either that they have comorbidity or they're more likely to have an atypical Parkinson's disease. There is no known marker yet, and probably there is going to need to be more than one marker. We'll probably be using genetic markers and some spinal fluid markers, and maybe things like the functional MRI, which is a specific test for the MRI, and the DAT scanner. Now let's talk about the non-motor symptoms, because as I mentioned previously, they occur oftentimes before the motor symptoms. I like to divide these non-motor symptoms into three categories. Number one is the cognitive and psychiatric category, then the autonomic category, and on the right, sensory and pain. So let's look at the cognitive psychiatric symptoms. We've talked about some of those. Anxiety is present in 50 to 70% of patients with Parkinson's disease. Depression is very important. Oftentimes, depression precedes the diagnosis in 50% of the cases, and it goes on through the disease. Fatigue is very common. 80 to 90% of patients with Parkinson's will have fatigue. Exercise helps that. Slow thinking, or what we call bradophrenia. Some patients will have hallucinations, but sleep dysfunction is very common. It may precede it. You have fragmented sleep, and a common phenomenon that can occur and may anticipate Parkinson's is REM behavior disorder. REM behavior disorder is where the patient's asleep, they have rapid eye movement, but unlike the normal patient where they can't move, the Parkinson patient can act out their dreams, and they yell, scream, holler, or fall and hurt themselves. Obstructive sleep apnea is also probably more common in patients with Parkinson's disease. Now, autonomic symptoms. They can have drenching sweats. They can have shortness of breath. They can have times where they drop their blood pressure or have orthostatic hypotension. And that can cause loss of consciousness. Usually occurs when you stand up. Sexual dysfunction. Seborrhea is dandruff around the eyebrows or in the nasal or hairline. Constipation we talked about. In a study in the Asian population in Hawaii, if you had less than one bowel movement every 3 days, you had a chance of having Parkinson's disease greater than the normal population. And of course, urinary urgency and frequency. Sensory and pain symptoms are common. Numbness, tingling, a restless-like sensation that wants the patient to get up and move. We talked about olfactory loss. 80 to 90% of the patients with Parkinson's have loss of their olfactory sensation. Diffuse pain, back pain, and shoulder pain isn't a common phenomenon, and later in the disease, it certainly occurs more. Hot and cold sensations, burning, restless leg is thought to be increased, and of course, neuropathy. I want to briefly go over some of the motor and non-motor symptoms that are associated with wearing off. Wearing off is a term where there is a progressive diminishing of the therapeutic effective response that the patient experienced before. And it usually occurs especially in L-DOPA, but sometimes in dopamine agonists, not usually in other medicines, but L-DOPA is the one it's most associated with. And we have the motor offs, and they're tremor, bradykinesia or akinesia or slowness, rigidity, and postural instability. But this is an example where the patient takes their medicine. L-DOPA has a 90-minute half-life, and it starts to wear off with effectiveness, and before the next dose, they get any of these symptoms. The same is true for non-motor symptoms. Fatigue, anxiety, depression, mood changes, difficulty thinking, pain, and salirrhea, excessive drooling, is often seen. We talked about sleep disturbances, very common. 98% of the patients probably have sleep disturbance. You can have difficulty with sleep initiation, maintenance. You can have periodic leg movements or jerking when you're asleep. We talked about REM behavior disorder, and many patients have excessive daytime sleepiness. The sensory symptoms in review, muscle cramps are very common. Stiffness, dystonia. Dystonia often occurs in off time when the patient is wearing off or has endose failure or a motor time where they're getting worse. Often occurs early in the morning. And we talked about burning, tingling, and numb sensations. So why do we want to treat and diagnose early? We want to diagnose right away and treat early in most cases, because you want to have your patient to have the best quality of life, activities of daily living, motor function as best possible. We want to improve their behavior and cognition, reduce caregiver time, reduce caregiver depression, and we want to reduce nursing home placement. Now, how do we think about treatment? Well, we think about it in non-pharmacological aspects and in pharmacological. The non-pharmacological aspects are very, very important. We want you to know about the disease. Family members need to know about the disease. The patient needs to know, and the caregivers need to know. The more you know, the better you do. Knowledge is power. You want a support system. And importantly now, you want to exercise. And we already mentioned 1 hour for 5 days. Getting your heart rate up to a 60 to 80% max heart rate is important. We're not going to talk extensively about pharmacological medication, but we generally start with an MAO type B inhibitor like selegiline or rasagiline, and we start that when the patient is mild, has very minimal disability, and then we go into a dopamine agonist, which is ropinirole, pramipexole, or rotigotine patch. But as the patient progresses, they're all going to need L-Dopa, and L-Dopa is the most effective drug we have. And for patients who are cognitively intact, have Parkinson's disease, who do well with L-Dopa and they're very responsive, we can later think about deep brain stimulation. The future in neurodegenerative disease and in Parkinson's disease is the biomarkers. And we have more things that are available. We're going to be talking about fine-tuning and giving more sensitivity to the MRI. We're going to be using the MRI spectroscopy, functional MRI. We're going to be doing diffusion tensor imaging. We're going to look at CSF markers like we're looking in Alzheimer's disease. Genetics, we're getting more and more understanding about genetics in Parkinson's. We're going to discover more and more genes. We're going to find out that genes actually have interaction, and there's polygenetic interaction. The question is, will we be able to find out how genes help us with therapy? Maybe we will. Stem cells, we're still in their infancy. The important aspect about stem cells, we need more understanding of how those work. There's certainly problems with that. We're thinking about now implanting through various vectors trophic hormones into the basal ganglia. There's new concepts about the etiology of dementia and also about other non-motor symptoms like anxiety and apprehension and fatigue. There's a whole concept now about white matter dementia, white matter dysfunction, that may play a role. Interesting now is a concept about cell-to-cell transmission of proteins. And there's been evidence through several doctors that have shown there's a possibility of proteins such as maybe beta amyloid and alpha-synuclein can be transmitted from, say, a presynaptic neuron to a postsynaptic neuron, called synaptic transmission, like we showed you. If that's the case, then this disease may have some kind of neurotransmission basis, and it would make it difficult to help the disease with things such as stem cells. What we really need today is a better understanding, more education. Everybody needs to be their own advocate. They have to really understand about their disease. The family has to be involved. You have to exercise. Exercise has been shown to delay the progression of the disease in Parkinson's disease. You got to have surrounding support. But more than anything, I think what we need is individual responsibility to help improve our quality of life and improve our activities of daily living. Thank you for joining us today on this topic of Parkinson's disease. This series of programs has been funded by the generosity of the Bell Foundation in honor of Glenn W. Bell Jr., founder of Taco Bell, and by Elaine and David Darwin.